Hi, everybody. So we've got a very packed session and we're going to try to keep to time to help with people's various airport departure times. So please sit down, Matt. So our first speaker is Tim Rhodes. Tim is Professor of Public Health Sociology at the London School of Hygiene and Tropical Medicine and Professor of the Sociology of Health at the University of New South Wales. And he uses qualitative methods to explore the social relations of harm reduction and evidence making. Tim.
How do I move slides then? Oh, it's here. Brilliant. Fantastic. Thank you very much. Okay, so I'm going to be talking about outbreak and outbreak science. And the talk is a little bit of a think piece. So try and bear with me as I go. And I'll try and fit it in on time, I promise, Sarah. Thank you to my co-author, Kari Lancaster, also at the University of New South Wales too. So the main point is to invite us to think a little bit differently about outbreak, the configuration of outbreak, and how that might help us think differently about outbreak science and outbreak as a form of early warning. So we're kind of asking, what does the configuration of outbreak do? You know, by enacting something as outbreak or indeed crisis, how does this problem then get seen and governed? What are the implications of that? So I'm going to give you the conclusion at the start. So we're going to suggest that outbreak is usually enacted in early warning science and policy as a rupturing event of an anticipated threat to come, which enables rapid and reflex precautionary control based largely on short-term and proximal early warning indicators. And we're going to make a case for an alternative view of outbreak. We're going to argue that we should slow down our reasoning in order to resist reflex responses. And we're going to do this, we hope, by thinking about how we might think about outbreak in long view and differently. Now, our case for doing this is a rather familiar crisis to many of us, which is the opioid overdose crisis, which is affecting many places in the US and North America. So shown here is a CDC slide, I'm sure we've all seen this, which illustrates a very long entrenched epidemic of overdose. And since 1999, according to the CDC, there's over 900,000 people in the US that have died of drug overdose, and deaths have quadrupled over the past decade, with overdose now the leading cause of death in the under 50s in America. So if we look at the science of epidemiology and the narrative of opioid overdose crisis, within this science, a little bit more historically, it's told in usually three waves. And some of this work, this slide in fact draws on the work of epidemiologists Jalal and Burke from 2018 in their landmark publication in Science. We can see the spikes of outbreak in this exponential curve. So the story usually goes wave one, in the late 1990s, saw the rapid rise of prescription opioids to treat chronic pain, linked to the aggressive marketing for opioids for pain relief by pharmaceutical companies, enabled by weak regulation. Wave two, from around 2010, saw prescription opioid overdoses stabilize at high levels, but with a sharp rise in heroin overdose, as opioid prescription misuse morphed into heroin use and expanded into heroin availability. Wave three from 2013 is usually associated with fentanyl and synthetic drugs and a spike of overdose related to these. And since 2020, there's also been another spike of hyper-exponential growth, linked, it is said, to polyuse between stimulants and opioids, and perhaps also exacerbated by COVID-19 pandemic. Now, at the time, Jalal and Burke noted that this was, to quote them, a dismayingly predictable exponential trajectory over 4 decades. They described this exponential as a purely statistical association or observation, and they said that the drivers of this remain largely unknown, but they speculated that there were long-term processes at work and that these might be of social and economic orientation. So this 40-year exponential overdose crisis in the US was declared a national emergency by the government in 2017, decades after outbreaks were epidemic and even endemic. So I think already and immediately we can see a moment in time declaration of national emergency or crisis eventuating an outbreak of one kind which is different or in tension with other versions, which might be described better as a slow emergency, as something more endemic, as something more ordinary and ongoing. We see here a quote on this slide from social theorist Lauren Berlant, and she writes that the genre of crisis can distort something structural and ongoing within the ordinary into something which seems shocking and exceptional. So can we consider then what the genre of outbreak and crisis that gets done in science and policy does, and how it might kind of, I guess, blur or not help us see what might be described as the crisis ordinariness of slow emergency or slow violence. So let's get into this. I'm going to say a few words about how we might think about outbreaks sociologically very, very quickly. I'm going to make three very quick observations. And in terms of how outbreak might be configured as an early warning. First, and most obviously, there's the logic of epidemic. In epidemiology, it's usually the case that outbreak signals epidemic potential, a threat to come. This also means that outbreak is usually held as distinct from conditions that are ongoing or endemic. Incidentally, the logics of epidemic also imply contagion and a tendency to think of drugs like contagions, like viruses, as a threat to be controlled. Second, there is novelty. Outbreaks tend to present as new. This means that harms imagined in an outbreak event are imminent. They're yet to arrive, if you like. Not so much an if, but a when, an anticipation. So the declaration of an outbreak can imagine anticipation of threats, sometimes of monstrous proportions, threats that need urgent, decisive, and precautionary action. And all of this is quite familiar when living in a pandemic, of course. But what it means is that outbreaks can also be seen as the making of epidemics. We suggest that endemics, the crisis ordinary, can be remade, if you like, as epidemics through the configuration of outbreak, or indeed the declaration of crisis. I'm going to go back, actually. There's one final point in terms of thinking about outbreaks sociologically, and this relates to temporality. Of course, a key thing to do with outbreak and its declaration is speed. And there's a number of different kind of implications of this in terms of the temporal logics of outbreak, if you like. The first is that outbreaks tend to be seen quite proximal and in a short-term horizon. You know, outbreaks they're new, they're now, they're in the moment. Second, they're often seen as a kind of sudden and problematic rupture, if you like, as something which breaks out in an unwanted or dangerous way, I guess. And thirdly, as I said, or implied, they usually demand a rapid or precautionary response. You know, they require immediate control before they get going, before they get completely out of control. And I think it's this reflex of speedy, rapid, precautionary reflex control, which is kind of embedded in this idea of outbreak and outbreak response that we want to question. Let's turn to one example of outbreak science very quickly, and that relates to the idea of prediction. It's one key technology in early warning, which is being applied in relation to opioid overdose as well, as a means to act in order to that anticipated threats become more controllable, I guess. So the extracts to this slide, there we go. As the extracts to the right of this slide show, there's quite a lot of promise attached to the idea of prediction as a means of moving towards or promising prevention. And there's quite a lot of investment in this area. The idea here, as this image illustrates, I think, is a move to look towards the future in time, beyond risk assessment, beyond early detection, to forecasting. Now, Forecasting, at least short-term forecasts, are kind of taken for granted in outbreaks. We know this from COVID-19, other pandemics. And they tend to be grounded in the more or less known via empirical indicators whose veracity or accuracy is said to be certain enough to produce some kind of statement of probability or forecast. So in fast-moving viral pandemics or epidemics or outbreaks like COVID, for instance, short-term forecasts tend to be restricted to weeks. In the field of opioid overdose prediction, they tend to be around 6 months to a year. But the evidence-based credentials of prediction rely specifically on their capacity to link with empirical observations of the recent past. And this protects against, if you like, a wilder uncertainty or speculation of longer-term scenarios. So there's some really interesting work going on, I think, at the moment around prediction in relation to opioid overdose, including that done by Anique Borquez, Charlie Marks, and Natasha Martin at San Diego. It's just one example. But their work kind of illustrates how prediction as an early warning can do a number of things. It shows that recent detections of changes in drug supply, such as the presence of synthetic fentanyl, for instance, can be linked to subsequent overdoses and deaths. Their work shows that retrospective analyses of the last year can make overdose deaths predictable in the next year. And really interestingly, and for the first time in the US, models are predicting geographically targeted future overdose death rates as a device of early warning for national policy, indicating where outbreaks will next or might next occur. But prediction is no long view. In fact, predicting to prevent accentuates a short-term perspective to enable a rapid and tailored local response with sufficient measurable certainty. As the quote to the right of this slide shows, the timescales are of 1 year or less, and that's justified for a number of reasons. So it's couched as an emergency localized response. So that's 3 minutes? 3 minutes. I think that enacts a kind of temporal cut in the long view of overdose or outbreak. So can we see things differently? Can we see things in longer view, if you like, to try and move beyond this mainstream configuration of outbreak or epidemic? Now, if we look at epidemiology, there is some nice work which is tracing the long view of opioid overdose crisis, and there's two main narratives in this if we were to review it. There's the deaths of despair narrative, which was first coined by Anne Case and Angus Deaton in 2015. And this kind of locates opioid overdose crisis in a half-century process of deindustrialization, entangling unemployment, underemployment, reduced pay, weakened labor unions, community, family disintegration, and so on, producing very precarious conditions, which are conducive to drug demand and also pain relief. And then there's a narrative of despair, which entangles with supply. And this is seen again in this work, usually as part of a 3-decade process linked to largely the pharmaceuticalization of society, linked to the very aggressive marketing and power of pharmaceutical companies, enabled by weak regulations, as I've said earlier. So taken together, this epidemiological work on the long view kind of implies an ecological early warning, something which is based in a much longer kind of time frame. Likewise, we can look at how sociology is enacting outbreak in long view in relation to opioid overdose. And I'm going to skip through this incredibly quickly. But were we to review this field, I think we would find that one narrative in sociological work relates to class. And here's just one example based on work by Sam Freeman. So this scenario traces the long view of outbreak to post-war shifts in neoliberal society, enabling the right of companies to make profits, thereby producing economic inequality, recession, weakened unions, weakened worker protections, and so on, as well as weakened social and public institutional supports. So in this narrative, economic inequalities are materialized in work opportunity and workers' conditions. It's locating opioid overdose, if you like, as a workplace industry. And obviously there's a whole bunch of work looking at the racialization of opioid overdose and how that, wrap it up. It says I've got 12 seconds. Okay, we could go on much longer. Where are we? Let's bring ourselves to a conclusion. I'm going backwards. Yeah, so there's threads of Longview in EPI, there's threads of Longview, I can't find my slides here, in sociology, and this is bringing us, I hope, to seeing, let's use this as our concluding slide. Thinking of outbreak more as a kind of slow violence. And I think just to make this point, rather than to ramble on, let's just read out what Rob Nixon says of structural violence, because it's a neat quote and it tries to capture what I'm saying. By slow violence, I mean a violence that occurs gradually and out of sight, a violence of delayed destruction that is dispersed across time and space, an attritional violence that is typically not viewed as violence at all. Violence is customarily conceived as an event or action that is immediate in time, explosive and spectacular in space, and as an erupting into instant sensational visibility. We need, I believe, to engage a different kind of violence, a violence that is neither spectacular nor instantaneous, but rather incremental and accretive, its calamitous repercussions playing out across a range of temporal scales. So yeah, I'd like us to think how we can model, how we can build narratives, how we can do early warning of an ecological kind which sees outbreak in Longview and not just as a rapid precautionary enforcement response.
Thank you, Tim. Unfortunately, we don't have time for any questions. We're moving on in the program, and I'd like to welcome Sharon Hutchinson. She's a professor of epidemiology and population health at Glasgow Caledonian University and a consultant at Public Health Scotland. And she's a well-known face to us here at Inch.
Thank you, Martin. And that was fascinating from Tim. I think it needs a longer presentation next year. That would be great to get a bit more discussion on that. So I'm pitching that to my Greek colleagues for next year. So I'm presenting this on behalf of Andy Macaulay and a team that we've got working on this across Glasgow Caledonian University, Public Health Scotland, Bristol, and Scottish Drugs Forum. And this particular analysis was funded out of it was really a small grant that we managed to secure during the pandemic that really helped to set up a programme of work which we've kind of labelled under Ephesus, evaluating the impact of public health interventions and reducing harms related to substance use in Scotland. And a bit of background on Scotland then. So OAT is available free through the National Health Service in Scotland, has been for many years. But interestingly, there's been no evaluation of OAT in Scotland, particularly in the period since the rise in the number of drug-related deaths from 2015 to 2020. So we were really interested to examine the extent to which OAT is protective over that time, and whether it varies, that protection varies over the course of this rise in drug-related deaths. Now, Scotland's got a track record in doing record linkage, and particularly really linkage work we've done on hepatitis C has really helped to inform our public health response, and been calling upon doing a similar initiative to investigate drug-related deaths and wider harms. And we had an opportunity during the pandemic to set up such an initiative, initially to look at COVID and vaccination, and now we're adapting that to look at drug-related deaths and other harms as well. So essentially here what we have is on the left-hand side is an extract of data on individuals that are prescribed OAT in the community, and we've linked them up to a range of data, laboratory testing, hospital admissions, deaths data. And we got a large cohort of individuals, over 46,000 individuals that have been prescribed OAT between 2011 and 2010, and individuals so we can link to these other data. Two-thirds male, majority aged between 25 and 45 at the point of cohort entry. Vast majority being prescribed methadone, 68% here only prescribed methadone over our study period, an additional 22% prescribed either methadone or buprenorphine. So methadone's been the key or the main OAT in Scotland. A relatively high proportion of this cohort died. 15% of the cohort had died during our follow-up period. About 4,000 drug-related deaths. Now that 4,000 drug-related deaths represented about half of all drug-related deaths between 2011 and 2020 in Scotland. So, you know, a high proportion of the deaths are within this cohort that we're studying, and the vast majority of them are opioid-related deaths. So a key outcome measure here is drug-related deaths. And here, just showing the kind of crude drug-related death mortality rate. So we're looking, our follow-up period is from the start of 2011 right through to the end of 2020. We're censoring people at the date of death, at the end of follow-up, or indeed for those that are off OAT, we're ceasing censoring them at 24 months post stopping OAT medications. So here you can see a trebling in the rate of drug-related deaths over the follow-up period from 6 per 1,000 person years up to 21 per 1,000 person years. Highest, as you would expect, amongst the older cohort. But what's key here is we're seeing a rise in drug-related death rates across all our age groups. And here, this is according to whether individuals are on or off OAT. So the red line at the top are those that are off OAT. And you can see it consistently across the study period. Those that are off OAT have a higher rate of drug-related death than those that are on OAT. But what you also note here is the rise in drug-related death risk is not just rising for those that are off OAT, but we also see a rise in that risk for people that are on OAT. So in an adjusted analysis here at the top, we find that those that are off OAT, they have over a threefold increased hazard of a drug-related death compared to those that are on OAT. So that's accounting for other factors. And indeed, there's a higher risk for older age. We see a higher risk for the latter part of our study period, so 2017 through to 2020 is a higher risk in that period compared to the earlier period, and that's accounting for the other factors here. So at the moment, we can't explain the higher risk in that latter period with the information that we've plugged into this model. There's a bit of attenuation, but there are other factors that are playing into this that are related to the rise in that latter period. What are the factors? So higher risk for those that have been diagnosed with hepatitis C, higher risk amongst other comorbidities, those admitted with a mental health condition, non-fatal overdose. And here, just to highlight again that if you stratify this according to different periods, what we see consistently across all of the calendar periods, we see a higher risk, about a 3 to 4-fold increased hazard for those that are off OAT compared to those on OAT. But we also see this threefold increased risk over time in drug-related death risk for both those that are off OAT and those that are on OAT. So where do we sit internationally then? And this is Sarah's a kind of systematic review, meta-analysis on drug-related mortality. And really we, you know, at the upper end, we're topping the charts here. There's a couple of studies from Norway and Sweden. I think they're smaller scale than ours from Scotland. So we're very much at the top end in terms of our drug-related mortality risk at 13 per 1,000 person years. We do, however, find a very strong protective effect for OAT. Here from Tom Santo's meta-analysis in JAMA Psychiatry, where they found a pooled relative risk of a 60% reduced risk of I think this is drug-related mortality. We see a higher reduced risk, 70% reduced risk in our Scottish cohort. So key points from this then, this is a large and national cohort, and I think it will really help us to improve our epidemiology of drug deaths and drug harms, and I think it's been really lacking in the context of a public health emergency, and we really need to do more work on this to better understand how we can reduce the risk of a drug-related death. We find a very strong protective effect of OAT, but because of that rise in OAT amongst those that are on OAT, clearly more work needs to be done to improve the effectiveness of OAT, but I think it does also point that OAT on its own is not going to be sufficient to really address this drug-related death crisis in Scotland. And more work's really needed to better understand what are the factors driving this really rapid rise in the numbers of drug-related deaths in Scotland. Various hypotheses here, and we're doing more work on various things, including looking at prescribed benzos and illicit benzos to really, I think that's a key area for us to try to understand the role of polydrug use in driving the drug-related death risk. And but what we have seen through this analysis, that certainly a factor that was really being used to explain the rise in drug-related death risk associated with the ageing cohort effect. I'm sure the ageing population is making a contribution here in terms of the numbers of drug-related deaths that we're seeing, but it's certainly not the sole factor that is driving this epidemic. And so that's really helped, I think, for us to enable us to look at other causes. And if I can maybe just indulge on this last slide, and does relate, of course, to our drug-related deaths crisis. We had the privilege of hosting INSU last year in Glasgow, and indeed we held a policy day ahead of the conference on supervised consumption sites, and we had experts around the world that came to Glasgow and talked about their experience about both implementing and evaluating consumption sites. And we're now a year on from that, and Glasgow City, which has the highest drug-related death risk in, I think, the whole of Scotland, has now been given a green light to introduce a pilot safer drug consumption facility. So that's, it's a long overdue, but important milestone for us. So just wanted to say thanks to INSU and thanks to all the experts who came and gave their time to that policy day last year. Really did energise efforts for us in Glasgow, and yeah, it's a lot of work now to be done. Thank you very much.
Thank you, Sharon. We have time for a few questions. And let me remind you also that you can put questions into the conference app. And we see them on a tablet here. So any questions from the audience? So then I have one question.
You can give a question to Tim as well if you didn't have any questions.
So Sharon, do you see any distinct trends in causes of death between the two groups, on and off OAT?
Well, we've only what you mean broader than drug-related deaths?
Yeah, I mean, it could be quite broad. I mean, it could be external causes, overdoses, suicide. It could also be chronic diseases.
Yeah. Well, that's so we've got a host of studies now that's going to really need to. This was a kind of a start of 10 really for us to understand, the kind of really understand because people have only been characterising the kind of numerator, not the denominator, in terms of drug-related deaths. So this was our first goal, really, for us. And so I think, we need to do that wider work. There's still a large number here that are dying from other causes and not drug-related deaths. So that's actually a separate project where we need to kind of drill down and look at wider causes beyond just drug-related deaths. So no, we haven't done that kind of work yet. I think there's someone else on you.
Very interesting presentation. I'm wondering what you know about the deaths in relation to illicit benzos. Is it people moving off heroin altogether and just solely starting to use illicit benzos that are kind of driving part of that peak? And if that's the case, how do you respond in different ways?
I think it's not just people that are. It's polydrug use, so people that are using heroin, and there's a whole combination of drugs that are at play. We've seen a real shift to injection of powder cocaine, particularly in Glasgow, and I think it's spreading out now as well. And you can see that even in the kind of routine data, we've seen this rise, and benzodiazepines as well appearing in drug-related deaths. And yes, indeed, how do we manage that?
Yeah.
I think that it's a key challenge, and we need to look at what changes has happened in prescription use as well, and if that's playing into a rise in illicit benzo use. So I think there's a lot to be done.
Yeah.
I don't know if there's experience from other countries that we can draw on that's actually had to tackle this.
Yeah. Thank you.
Thank you so much, Sharon.
I just realised we didn't introduce ourselves. We didn't wander off the street. I'm Sarah Lani. I'm at the University of Montreal.
And my name is Martin Kåberg. I'm a senior researcher at Karolinska Institute, Stockholm, Sweden.
So, that out of the way, I will introduce our next speaker, who is Julian Shuri. So he's bloodborne virus clinical lead for Find and Treat service, conducting community testing and linkage to care for hepatitis B, C, HIV and syphilis for underserved populations and marginalised groups. And he is a research fellow at the Institute for Global Health at University College London. And research interests include inclusion health, integrated outreach, point-of-care diagnostics, and peer-led interventions. And he's speaking on cardiovascular disease in people who are homeless. Take it away.
Thank you very much. I'm from the Find and Treat team in London, and we'll be discussing our study. It's a cardiovascular disease screening of homeless individuals. It's a feasibility study, and this was led by a colleague and a friend of mine, Ami Banerjee, who got funding from the NIHR in the UK. So a little bit of context from the Find and Treat team, if you don't know us already. We're a pan-London inclusion health team. It's multidisciplinary, and we have interventions such as TB. We have a mobile chest X-ray van. We have vaccination service. We do more recently COVID vaccinations, influenza, pneumococcal vaccines, and a bit of Hep B. That's hard work, unfortunately, at the moment. And the bloodborne virus team that I work in, we do Hep C testing, HIV, Hep B, and STI testing. The idea is we try and make every contact count. We have a high proportion of people with lived experience work with our team. We are in the NHS, and that's a bit more structural. It's quite difficult to get our peers into a higher, well-remunerated grade compared with other organisations. We are trying, it's a co-designed service, and we rely very much on participatory research. And that's the guy. You can see on the top right is our chest X-ray van. The top left is our BBV van, and we try and do all the things amongst all the vans. So a little bit, inclusion health service, but what does that mean? We use definitions, so it's a service, research and policy agenda that aims to prevent and redress health and social inequities amongst the most vulnerable and excluded populations. In our particular target populations, we target people experiencing homelessness, drug use, imprisonment, and sex work. And as we know, these populations have multiple and overlapping risk factors and high levels of morbidity and mortality. In the UK, so the increases in life expectancy have been slowing for a number of years, and we actually saw a decrease since 2018. We could attribute this to, some people attribute this to austerity policies implemented in the government since 2010. Maybe that is a coincidence. And maybe we should have got Frankie Borough basically Glasgow last year. He could have been an ambassador for INSHE. But essentially, against this backdrop, we can look at the outcomes of inclusion health populations in terms of morbidity and mortality. This is, if you don't know it, it's the indices of multiple deprivation. If you chop up the population into the most deprived and least deprived. So on the right-hand side, you have the least deprived, and on the left, the most deprived. And you see the loss in life expectancy has been greater in poorer populations, in the more deprived populations. So similarly, this uses the same concept, but this is the loss. This is the, this is how long you'd expect to stay in good health. And males typically in the most deprived areas would spend 3/4 of their life in good health, and females that's down to 2/3. So welcome to Britain, lovely place. If you look in terms of people experiencing homelessness, however, instead of having that slope, so this is just the same concept. This is in fifths instead of tenths, but you get the same idea. You've got this slope of an increase in various diseases such as asthma, COPD, epilepsy, heart problems, stroke, and diabetes. And you see that increase as you get most deprived populations. When you reach the populations that are experiences homelessness, instead of that slope, there comes a cliff. So huge increases in most of these conditions, apart from diabetes. So, excuse me. So it's in this context that we devised, so we know that the risk and burden of a cardiovascular disease is higher in people experiencing homelessness. So it's in this, however, population screening largely excludes people, inclusion health populations. So in this context, we aim to investigate the feasibility of a dedicated mobile cardiovascular screening service for homeless individuals and estimate the prevalence of risk factors and burden of cardiovascular disease. Prior to commencing, we carried out some co-design. This was some 4 focus groups, and about 16 men and 9 women, and all were aware of cardiovascular risks and relevance of healthy lifestyles. They identified several barriers of prevention to prevention and health access. That included disorientation affecting planning and self-care, lack of facilities for food, hygiene and exercise, and experiences of discrimination. And they had some recommendations as to how the cardiovascular care should be addressed, and this should account for fundamental problems of the environment, be co-designed with service users, and cover some key principles such as flexibility, public and staff education, integration of support, and advocacy for health service rights. So in our study, we co-developed and implemented a 15-minute cardiovascular assessment for people experiencing homelessness, and we just embedded that in our normal BBV and other outreach work. So it consisted of a questionnaire, so there's basic demographics, past medical history and some symptom data, and then some other measurements and point of care measurements and blood pressure and stuff like that. So we've got blood pressure, ankle brachial index, which is looking at the difference between your arm and your leg, looking at peripheral vascular disease, cholesterol, glucose, and HbA1c was a measure of diabetes, and little mobile ECG to look for atrial fibrillation. So atrial fibrillation is top of the heart wobbly syndrome. So the atria is at the top of your heart, and fibrillation is wobbly, and what can happen is if that happens, you can get blood clots or you can get a fast heart rate, palpitations from below. This is our questionnaire. Everything was like yes, no, are you having any treatment for it? Anything severe or anyone's having severe palpitations or breathlessness, then they would get an accompanied, a peer would accompany them to either a GP or ED department, depending on the severity. And we did some basic demographics on ethnicity, height, weight, so we could do a BMI and age. Here's our measurements. They just give you an idea that anyone was particularly severely hypertensive, then they may have to go to see a GP or A&E, similar to some of the other measurements as well. We can take it out in a little wheelie sort of bag you take through the airport. So these are all the bits and bobs. So there's point of care. We trained the peers to do this as well alongside us, so it's quite accessible. And we did some post-test education and support. This is the HbA1c, and you can see my grubby thumb there. There's you only need a tiny, tiny little bit of blood, and you get a result in 3 minutes. And this machine actually can also do a CRP, which we're going to be linking in to some of our chest X-ray work and chest infections. On the left, you've got a little mobile ECG machine. There's two versions. You just put your finger on it, you get a little rhythm strip, and you can send yourself a PDF. And on the right is the CardioCheck machine that you'd get glucose and cholesterol measurements in about 2 or 3 minutes as well. So we came across like 650 people, 656 people were approached. About 80% recruited between May 2019 and 2023. We had a little break in COVID. It's across like, our routine testing sites, about 75 sites. Mean age about 47. That's typically of the population that we screen. Mainly male, about half of white, white British, sorry. And a fair amount have had a previous cardiovascular event, 15%. So briefly, so these are the self-reported clinical history. So high rates of current or previous smoking and family history of sudden death was common, just over a quarter. So in terms of the clinical results, nearly half had high blood pressure. This is all untreated, by the way. Half had high blood pressure. Although 2% have reported high cholesterol, it's a quarter had a high cholesterol measurement. In terms of diabetes, so there was suspected diabetes in about a quarter of the South Asian British origin population, and that compared with 18% in Black British and 5% in White British. And the prevalence of AF was high, at about 12, and particularly amongst the young. These are quite small numbers, so we wouldn't really want to extrapolate this in the population level, so this was very much a feasibility project. We also counted a Q-risk score. So Q-risk score is looking at see how, what's the likelihood of having a cardiovascular event in the next 10 years using some of the measurements that we collected. And we found that 1/3 had a risk of more than 10% of 10% had a Q-risk score, 30%. So a third had a Q-risk score of over 10%, basically looking at the 10% risk of having a cardiovascular event in the next 10 years. And this was consistent across the other ethnic groups. Other countries use different measurements, and 10% would be the threshold that you'd be likely to be having treatment, so for example, a statin for high cholesterol. Ooh, blank slide. So just to wrap up, so it's a simple, pragmatic cardiovascular assessment for homeless individuals, and it's feasible and very acceptable. We actually used this. This ended up being an incentive for people to get on the van and use our other services. Identified gaps in diagnosis and prevention. There's a high burden of cardiovascular risk factors and cardiovascular disease amongst homeless individuals. And this could be addressed with the integration of cardiovascular screening into existing inclusion health outreach frameworks. Thank you very much.
We do have a few minutes for questions. Are there any questions for Julian?
Hi, Amy Plymmer from Public Health Wales.
Hi.
I just had a question about, you talked about if they had certain markers, you'd recommend they go to a GP, agree. But when we think about linked to care and homeless people, what about the ones who aren't registered with a GP? Was there someone on site that could help them?
Yeah, so that's very much part of our work. So we either, the peers that we employ or we work alongside, for example, Groundswell, which is a fantastic organisation, and that's one of our first screening questions. So they did the cardiovascular test as well as our normal screening thing we do for BBVs, and one of the first questions, are you registered for the GP? And if they're not, then we will try and we'll help them, and that peer would either take them there or we'll deal with a key worker. So yeah, key important is primary care. And when we're thinking about what we're doing with this cardiovascular thing, I don't think we want to kind of create a whole new sort of treatment protocol. We're probably thinking we need to improve the access to primary care for these individuals. So this is a good screening tool, but rather than reinventing a whole service, we just need to improve the way people access primary care, I personally think.
I guess sort of carrying on from that, then I was thinking about the smoking and how it can be very difficult to engage with smoking cessation with populations where smoking can be a bit of a currency. But it sounds like the goal isn't really then to give people a vape or something. You just want to move them, try and get better access to primary care.
It's very much TBC. We've done this. This was like a research study, just a feasibility study. So like I say, we'd be cautious of extrapolating this to a population level. We know that, for example, that various cardiovascular disease, you've got homeless people experiencing homelessness have got twice the risk. So we're very cautious about what we're going to devise, and from a programmatic point of view. But very much, I think that'll be localised with the primary care service.
No, that makes sense. Is any other final questions or thoughts?
Hi there. Just wondering if you're able to identify, say, uncontrolled diabetes or hypertension, that sort of thing. Are there strategies for helping people adhere to the medication regimes and follow-up blood work and all that? Can you
Well,
talk
exactly,
about
that's it. This is exactly, that's the rub, isn't it? These are long-term conditions that you're going to need long-term care. And we're very used to, as you see from our main work, is like you've got pretty much an end point in terms of treating TB or Hep C. We're getting that very much, we are branching more into HIV and Hep B. These are long-term linkages to care, and I think that will very much fit into that model. Whether our sort of design, I pretty much think ours is pretty much find these people, link them into care, and then hand them over, and there should be some long-term sort of primary care-based linkage and support. I'm not sure, it'd be really on our remit, I think, essentially. Not much of an answer, really, but if you've got that magic dust, then how to keep, long-term linkage to care is the main thing.
Thank you so much, Julian.
Thank you.
So we're now moving over to the short presentations. It's 3 minutes of presentation and 2 minutes of questions. And the first presenter is Samantha College-Frisbee. She's a postdoctoral research fellow at National Drug Research Institute, Burnt Institute.
Thank you so much. Hi, everybody. So I'm Samantha, but I'm actually presenting on behalf of Dr. Ashley Stewart today from the Burnet Institute, and I'm going to be talking about emergency department presentations for injuries to the head among people who inject drugs in Victoria. So by traumatic brain injuries, we're talking about injuries to the brain caused by external forces, and these contribute to deaths and long-term disability, as well as impact independence and social well-being. Globally, it affects about 69 million people every year. In Australia, there are anywhere from 46 to 275 cases per 100,000 person population. Substance use is an independent risk factor, and people in prison are more than 5 times as likely to have TBI compared to people in the community. Current estimates of TBI among these populations are quite limited. So we wanted to estimate the incidence of emergency department presentations for head injuries among a community-recruited cohort of people who inject drugs and a prison-recruited cohort of men who inject drugs in Victoria. These are our 2 cohorts. We have Supermix and the PATH cohort. Supermix were recruited in 2008, have been followed up annually, and we have linked data to about 2019. The PATH cohort is a group of men who have been were injecting in the 3 months before their index incarceration, and they have data from 2014 to 2019. We linked ED presentations to estimate the crude incidence rates per 100 person years, and we calculated these rates, we stratified these rates, by sex for Supermix, and we also looked at those injuries that are occurring inside the prison setting. So for the Supermix study, there were 451 participants who had 820 emergency department presentations for head injury, and this was about 37% of all participants in this study, and about 5% of all ED presentations. Most presentations were for an open wound, and 16% were triaged as emergency or non-urgent. The overall crude incidence rate was 6.25 per 100 person years, down to 4.64 for women, and up to 7.71 per 100 person years for men. For the PATH cohort, there were 121 participants who had been to hospital, or emergency, and they had 154 presentations, so 35% of all participants and 6% of all presentations. Most, again, were for an open wound or intracranial injury, and 1/4 were triaged as emergency or urgent, and 17% of those occurred inside the prison setting. Overall, the crude incidence rate was 8.46 per 100 person years, 4.65 for time in prison, and 8.58 for time in the community. So incidence of ED admissions for head injuries was much higher in our cohorts, as we might expect. Men in Supermix had almost twice the incidence of head injuries compared to women, but a lower incidence compared to men. A lower incidence compared to the PATH study. In the PATH study, incidence of ED presentations were much higher, but also almost 1 in 5 occurred in prison. So further work is definitely needed to understand the severity and ongoing impact of head injuries among this population, particularly with the compounding effect of overdose. Thank you so much. Ash is happy to take any questions.
Thank you so much. Any questions?
Yes, Peter?
I suppose in Supermix, some of those people may be coming in and out of prison. I was wondering whether you were able to determine whether the head injury occurred in prison or when in a community for those people.
Yeah, so the difference with the Supermix data is we haven't quite got the linked carceral setting information just yet. Once we do have that, which is not too far away, we should actually be able to look at that a little bit more acutely. Right now we just have self-report experiences of prison in the past 12 months. So we could use that, but I think it might be a bit better to use the linked data to look at that. Yeah.
I don't know if you'll be able to answer this, but I wonder if you could reflect on the difference in the percentages being treated as urgent, as triage, because there was a higher percentage in the prison, in the PATH cohort, that were triaged as urgent.
Yeah, no, unfortunately I haven't thought about this at all.
It'd be super interesting to look at.
I mean, it kind of, I suppose, like it would make sense that if someone has made it to the hospital from prison, it's probably an indication that it's more urgent. They would have some capacity to treat head injuries within the prison setting, I imagine. So I think it's probably just an artefact of that. There we go.
Thank you so much.
So our next speaker is Dr. Amanda Roxburgh. Amanda is an early career NHMRC research fellow with a national and emerging international profile. I think an international profile in illicit drug research. I'll edit that for you. Her highly cited work on opioid overdose mortality has influenced regulatory change in Australia, and she currently leads a research program investigating factors driving non-fatal and fatal overdose in contemporary drug markets. And she's my friend. And she's going to be presenting on women who inject drugs at the Medically Supervised Injecting Centre in Sydney.
Thanks, Sarah. Yes, so I'm going to be speaking about the women who attend the Sydney service. For those of you who don't know, there are 2 facilities in Australia, one in Sydney that opened in 2001 and a second one that opened in Melbourne in 2018. I'm looking at the administrative clinical data for the Sydney service. So just by way of background, probably everyone knows that among people who inject drugs, women make up 1 in 4 of this population. Despite this, they've got higher rates of risky injecting practices, higher rates of BBVIs in certain regions, shorter time to drug dependence, and they're at increased risk of physical and sexual violence. And underpinning these stats is largely structural and gender inequalities. Complicating this is when women are pregnant or when they have children, there's much greater stigma, there's greater barriers to service, and in actual fact, neither of the injecting facilities in Australia allow pregnant women to use their services, and women who inject drugs more broadly have poor sexual and reproductive health, but particularly women who are pregnant very rarely present for antenatal care. So there's been over 17,000 clients in the 20 years at the Sydney service. Interestingly, 1 in 4 of the clients are women, so that kind of matches up. They're much younger at service registration, well, quite a bit younger than men at service registration. There's a higher proportion of them who identify as being Indigenous. Unsurprisingly, men have 2 times the risk of having a prison history. They have higher rates of history of homelessness. There's no difference in terms of first age of injection across males and females. Again, interestingly, at registration, women were slightly more likely to report daily injecting, and there's no difference in history of overdose at registration. So looking at the vertical axis, this shows number of days accessed the service in any given year, and really what you can see is the red, the grey and the green lines represent the 5% of the cohort. So essentially across all of the years, there's really only about 5% of the cohort that attends the service daily or more. And again, if you look at men and women, there's really not that much difference, despite the fact that a high proportion of them had said that they were daily injectors. In terms of the drugs that they inject on site, heroin was slightly higher among women. Rates of injecting for heroin slightly higher among women between 2015 and 2018. I was a bit surprised by the fact that actually pharmaceutical opioid injecting was higher among men across the entire period. Amphetamines is really quite equal, and in the very early stages of the injecting centre, cocaine rates were higher among women, but cocaine's really not an issue at the moment. Looking at overdose, this is just crude numbers of overdose by men and women. So it looks like it's much higher among men. However, when we convert this to a rate per 100 opioid overdose visits, rates are similar until we hit 2018 and men diverge, and they've got 2 to 3 times the overdose rate between 2018 and 19. When we go back to just numbers, I mapped the numbers of heroin overdoses over the numbers by men and women, and we can see that it's actually heroin overdoses that's driving this difference for men during this period. So just some final thoughts. I've not said anything about gender diverse communities, and obviously they have a range of different issues that they also experience. This data doesn't speak to the violence that's experienced among the women who are attending the service. I guess within the context, particularly for the Sydney service, it's a fixed medical model. I think it would be very difficult to implement gender-specific services, whether you do it within hours for women only. Maybe mobile models might be easier. However, getting extra SIFs in Australia is really difficult at the moment. So how does the MSIC identify and respond to women's needs? They do a lot of training among the staff around how to identify domestic violence and how to respond in ways that isn't going to actually inadvertently make it worse. And the staff do, where they can, offer options where possible for women to attend the services separately from their partners. And finally, they're working on additional resourcing in partnership with another health service to try and get up a program of work specifically addressing the needs of women who inject drugs. And I'll leave it there.
I'm afraid we don't have any time for questions, but Amanda will be around in the break, I'm sure.
So we move on in the program. Next speaker is Vana Supsa. Vana is Associate Professor in the National and Kapodistrian University of Athens in Greece. She's a Principal Investigator in major community-based programs for people who inject drugs in Greece and has contributed in the preparation of the National Hepatitis C HIV plans. And she will probably be quite busy the following year here, preparing for INSU in Athens next year. She will have a talk on high levels of all-cause mortality among people who inject drugs in Greece in 2018 to 2022.
Well, thank you very much. First of all, I would like to thank all the people who inject drugs who participated in these 2 programs and made this analysis possible, and all my co-authors, in particular Sotiris Roussos, who was originally going to present here but couldn't travel. So we know that there are high mortality rates in the population of people who inject drugs. We don't have recent estimates, in particular covering the period of COVID pandemic, and we definitely don't have estimates for the mortality in Greece. So the aim of this analysis was to assess all-cause mortality and associated risk factors in the population of people who inject drugs during 2019 up to 2022. So the sample that we have used are people who inject drugs participated in two large community-based programs, one in Athens starting in 2018, and the other one in Thessaloniki that started in 2019. Approximately 2,500 persons participated and provided data from interviews and were tested also for HIV and HIV. Data on their vital status and date of death, in case of death, was obtained from the National Hepatitis C Treatment Registry using the participants' social security numbers that were obtained at first visit to the program for linkage to care. Out of the sample that we have studied, almost 93% had this information available, so they are included in the analysis that follows. We estimated the all-cause mortality using the date of death or the date of last follow-up using as the last date, 31st of December 2022. And we have also calculated the standardized mortality ratio, SMR, to assess the excess mortality in this population compared to the general population in Greece. The participants' profile, the majority of, in Athens, people who injected drugs and participated in these programs were more often homeless and unemployed. In Thessaloniki, we had more migrants. In Thessaloniki, most people used heroin, but in Athens, a substantial proportion used also cocaine. A large proportion of the participants in these programs were currently injecting, and only a small portion were enrolled in opioid agonist treatment programs. So the all-cause mortality rate in this population was, combining the two data sets from Athens and Thessaloniki, was 3.5 deaths per 100 person years, and you can see also the relevant 95 confidence interval, starting from the lowest is 3.1. You can see here also the trends over time in Athens and Thessaloniki. Athens is in red and Thessaloniki in blue. The overall mortality was higher in Thessaloniki, was 4.4 compared to 3.1 in Athens, but there was a statistically significant increase in trend in mortality over time in Athens. People who were at higher risk of death were people from Thessaloniki, older age, Greeks, homeless people, people with history of injecting drugs in the past 12 months, people with daily injection, and also people with HIV infection. Using this SMR, we have seen that people who inject drugs have almost 16 times higher mortality compared to the general population, adjusting for age and gender. Two limitations in this study are, first of all, that people who were excluded from the analysis because they didn't have social security number had a higher risk profile compared to those included. And the second thing is that migrants who might have left Greece, then in that case their death was not registered in the database, so all these two limitations may result in underestimating the overall mortality rate. So to conclude, mortality among people who inject drugs is high, especially in comparing to the meta-analysis performed by Sarah. It's higher in Thessaloniki than in Athens, even after adjusting for the differences in the two populations, but there is an increasing trend in Athens that we need to follow up. These data were used to advocate for the increased access to naloxone programs in Greece, and actually there was a recent change in the legislation for that, and we are currently working to estimate cause-specific mortality. Thank you.
We have time for one question. Matt?
Yeah, hi, Ben. I just actually sent you an email just about half an hour ago. And my question was, I'm Matt Hickman from University of Bristol. Well, I'm interested in the drug-related death mortality, but also whether you can use it to test the consistency of your capture-recapture prevalence estimates, because you should be able to then see whether are they consistent with the number of drug-related deaths in Athens that you're seeing, given your death rate that you'll see there. So there's quite an exciting opportunity, I think, to bring those data in.
We don't have data yet for drug-related mortality. Did you mention drug-related?
Yeah.
Well, for the time being, we are in all-cause mortality. And the deaths that are reported every year are related to drugs are in general low. So I'm not sure. I guess we need to see further the data that we have for that.
Thank you.
Thank you.
So our last speaker is Kristina Nizdilova. Christina is a PhD candidate at the University of Dundee, supervised by Professor John Dillon. Among others, she carries out a rescue study investigating the ability of chest-borne accelerator sensors to capture the respiratory pattern of people who use drugs and devices' acceptability to people who use drugs and stakeholder. And the title of the talk is Initial Process Evaluation of a Pilot Intervention Development Program Utilizing the Pneumowave Respiratory Monitor to Prevent Drug-Related Deaths.
Thank you very much. So, yeah, this is our disclosure of interest statement. And so in our study, the rationale behind it was that in the city of Dundee, which is in the central belt of Scotland, there is a high rate of drug-related deaths, and the majority of people who were found having an overdose in Dundee, 68% in 2021, had died in their own homes. So when people die in their own homes, there's nobody to give them naloxone. So unfortunately, those people passed away. So in our study, it was a mixed methods observational cohort study. The quantitative side utilized the Pneumowave sensor seen on the title slide, which attaches to the chest. It contains an accelerometer and it's mounted to the chest with an ECG electrode, and it measures how the chest rises and falls, and it measures that on 3 axes, which is X, Y, and Z. So during the study, participants were recruited from an injection equipment provision service in the city centre of Dundee. So we recruited 70 participants, 48 of whom came back with at least 1 week's worth of data. The time of monitoring was 4 weeks. 48 participants came back at least with 1 week of data, and 36 participants completed the full 4 weeks of the study. 22 participants were lost to follow up without submitting any data to us. So the way that worked was that there were 4 visits, and at each visit we would take the gateway device from them and we would upload the data to the cloud. These are the qualitative findings. So I interviewed 21 of the participants, 20 of which completed the full 4 weeks of the study, and 1 who did not finish. And we also carried out 8 focus groups with stakeholders, including the nurses who took part in distributing the devices and recruiting the participants. And these were the themes that we found. So we found themes pertaining to the identity and experience of substance use, intervention receptiveness and incentivization, and emergency responsibility. So ambulance was the preferred emergency response method, and the thing that motivated people to participate in the trial was mostly a strong therapeutic relationship with the nursing staff. In terms of the stakeholder focus groups, we identified barriers between people who use drugs and services, such as fear of the police. We also identified that there is a need for the intervention to be integrated into existing services, such as assertive outreach. And we also discussed the emergency response pathway, where it was the consensus was that people who would be using this device should have the right to choose who their responder is. So these are these are our current conclusions and our future study aims. So the current data suggests, if I'm just going to go back, these are 2 examples of study data. So we identified 8,614 apneic episodes of over 10 seconds duration and a total of 6,202.08 hours of data. So we did identify that this device is able to capture respiratory anomalies. So right now we are processing the respiratory patterns we have identified within the data and matching them to existing literature. And in terms of the qualitative data, we identified that experiences of overdose and drug-related death were identified as motivating factors for device wear. And first responder groups stressed that there is an importance of patient choice and device accuracy. And yes, we're currently identifying areas of interest within the study data, and data from other trials utilizing the device will inform the apnea detection algorithm alongside the data collected in the study. Thank you very much.
Thank you very much. Very interesting. Any questions? So just one, what would your idea of a trigger point be for first responders?
Sorry?
Your idea of where the trigger point would be for calling first responders?
Well, this is where we have hit a bit of a snag, because as you have seen, we have identified a huge amount of apneic episodes throughout the data. So what has become clear to us for reviewing the data so far is that people who have been on the trial, they have been experiencing apneic episodes all the time. Participants would fill in drug diaries during the study trial so that we would have information about their patterns. But we identified that people experience apneic episodes even in periods where they are not using drugs. So what a future study plan is, once we have identified the areas of interest and match them to existing literature, we will conduct a Delphi panel where we will look at the data and come to a consensus where we decide on the trigger points. Yeah. Thank you very much.
Thank you so much.